As president of the European Menopause and Andropause Society, it is a big pleasure to welcome you to the first virtual school of the Society, which we have dedicated to an emerging topic in women's health, as it is the challenges to health imposed by the specific conditions of survival from cancer. This is a fast-growing population with specific needs that we will address along these 2 days of our school. We in the board think it is a great opportunity to extend the educative benefits to a wide population. We have prepared everything for making this meeting very participative, and for that, I hope you are familiarized with the technical resources of our platform, which allows for raising questions to the speakers. You already know that we will have standard lectures, but also multiple choice questions and open questions addressed to the panel. We thank the speakers, the discussants, and all you for having chosen this educative activity of EMAS.
Welcome to the first session. Before the speakers start their presentations, we would like to explore the knowledge of all the attendees. We have prepared one multiple choice question for each topic, and you will have 20 seconds to give your vote. Please don't forget to click on the poll tab on the right side of your screen.
I would like to introduce you now to Dr. Begoña Bermejo. She is going to speak about breast cancer.
Good morning, everyone. It's a pleasure for me to participate in this Women Survivor Cancer Seminar. And I'm going to talk about breast cancer. I'm a medical oncologist, and this is my job. So I would like to divide the conference in 3 different points. First of all, I would like to talk about epidemiology. After that, I will talk about breast cancer, that I think is a typical model of treatable cancer according to its molecular profile. And at the end, I will talk about what is the systemic breast cancer treatment. About epidemiology in the world, we can see that when we talk about incidence, breast cancer is the most frequent cancer with lung cancer. And when we talk about mortality, we can see that lung cancer is the main cause of death in cancer, but it's not breast cancer. The incidence in cancer around the world is growing up. So we know that 1 of each 8 or 9 women will develop a cancer during their lifetime. So with those dates, we all know that breast cancer is a public health problem. What about USA? We can see also that breast cancer is the most frequent cancer in women, But when we go to see with the main cause of death, it's not breast cancer, it's lung cancer. The incidence of lung cancer is growing up in the last year, and right now in USA is the main cause of death by cancer in humans. But what about Europe? Also in Europe, the most common cancer site were cancer of the female, but when we go to see which is the main cause of death in cancer, it's not breast cancer. The main cause is, first of all, lung cancer, followed to colorectal cancer, and after that, in the third position, is breast cancer. Here we can see with the incidence and mortality in female, we can see that breast cancer is the most frequency cancer in female, and now in Europe, it's still the main cause of death in women by cancer. It's followed very close to lung cancer, but breast cancer is still the main cause of death in cancer in female in Europe. Here we can see with the distribution of the incidence in cancer between the age. We know that the most frequency are in women that are older than 50 years, but in younger people, we can see that there's also a high incidence of this breast cancer. Here we can see also we have been talking before about the incidence in the world. We can see the same in Europe, that the incidence in cancer is growing up, but the breast cancer incidence, it's staying in the same incidence. Here you can see the mortality in Europe. As you can see, the mortality of breast cancer is going down in the last 20 years, even higher in the last 10 years. And as you can see, the lung cancer mortality is going up. So right now, the breast cancer is the main cause of death by cancer in women, but we hope that in the next few years, lung cancer will be the main cause of death by cancer also in female. This as is the mortality in the different countries in Europe. In all the different countries in Europe, the mortality is going down, except in Poland. And as we can see, this mortality is going down in all the different group of age of breast cancer in women. So in conclusion, trends in breast cancer mortality were favorable. The falls were largest in women in the age of group that belong to the screening, but it's also seen in all the different age group. Cancer mortality will continue to fall, and this is likely due to improve in screening and also in the new treatment. Due to population aging, however, the number of breast cancer is not declining, the incidence remains the same, but the mortality is going down. What about breast cancer according to the molecular profile? We used to treat breast cancer based on the data we have by the histology, but in the last 10 years, we introduced the single gene prediction, and in the last years, we also have multi-gene prediction. So this allows us to give a treatment based on molecular and genetic markers. We used to classify the breast cancer according to the hormonal receptor status and HER2 status. So the breast cancer cell, when the breast cancer tumor cell express hormonal receptors, we used to say that it's hormonal breast cancer. When the breast cancer tumor cells overexpress HER2, we used to say that it's HER2 positive breast cancer. And when this breast cancer cell didn't express either hormonal receptor or HER2, we talk about triple negative breast cancer. But of course, in triple negative, we put together all different types of breast cancer tumor that didn't express this receptor. Fortunately, the most frequent breast cancer is the one that expresses hormonal receptor, and the less frequency is the triple negative that, as we will see later, is the more aggressive breast cancer type. But in the last year, we have been classified the breast cancer using the gene expression profiling, and we found 4 different types of breast cancer, each of type of breast cancer with a different prognosis and different treatment. As we can see here, the luminal A breast cancer is the less aggressive breast cancer with a high survival. And the most aggressive cancer is the basal-like cancer. But we don't have this option to carry out of analysis of genetic profiles in our patient, in our clinical practice. So we have made an approximation establishing a correlation with the histological data that we have. And also, of course, we don't have validated systemic treatment based on the genetic profile right now. So for luminal A breast cancer, we select the patients that are hormonal receptor positive, HER2 negative, and high low proliferative breast cancer. For luminal B are the patients that have a breast cancer with hormonal receptor positive, HER2 negative, a higher proliferation. HER2 enriched are the breast cancer that have overexpression of HER2, and basal-like are the triple negative breast cancer. As I told you before, also in the triple negative breast cancer, we can find a different subtype of breast cancer. But in our clinical practice, we use triple negative, which are very high proliferative breast cancer tumor, followed by HER2, and in luminal, we have two types of breast cancer. Luminal A, which are very low proliferative, and luminal B. This is important because in this type of breast cancer, apart of hormonal therapy, we need to select if the patient needs or not chemotherapy. Right now, in our clinical practice, we can use genetic platforms to determine how is the risk of the relapse of this patient with this type of breast cancer, and also which is the benefits of the chemotherapy. We can select three types of genetic platform: Oncotype, MammaPrint, Prosigna. I'm just going to show you an example that we use in our hospital, which is Oncotype. We use it for the patient that have luminal breast cancer, and we analyze which is the risk of relapse and how aggressive it is breast cancer, and we can determine it with the recurrent score. We can see that this patient have a recurrent score with very low. This means that it's not aggressive. And also we can determine with this test if the chemotherapy will help in improve in the survival in this patient or not. So breast cancer is just not a disease, it's a group of different subtypes. What about the systemic treatment? Hormonal receptor and HER2 are prognostic factor and also predictive factor because they are treatment target to determine which is the best treatment to do to the patient. With different type of treatment we have in breast cancer, we can use hormonotherapy, which is the most important treatment for breast cancer, chemotherapy, biological therapy, and we hope in the next year we will also introduce immunotherapy for the treatment of the early breast cancer patient. This is a schema of how we treat the patient with early breast cancer. What about hormonotherapy? We have different type of treatment. We have anti-estrogen, aromatase inhibitors, and also we use ovarian suppression for premenopausal breast cancer. Here is what we treat the patient when we talk about hormonotherapy. In premenopausal patient with low risk, we only use 5 years of tamoxifen. In premenopausal patient with high risk, we use ovarian suppression and aromatase inhibitor for 5 years. In postmenopausal patient, we give 5 years of aromatase inhibitor, except of the patient with high risk of relapse, with a patient that have 3, 4 or more lymph node affect, that we give hormonotherapy for 10 years. And also in the perimenopausal patient, we can use a switching system, which is 2 or 3 years of tamoxifen, and then change to 3 or 2 years of aromatase inhibitor. And this is important when after we will talk about which are the side effects of this treatment in this patient. This is the trial where we demonstrate that for the patient that are premenopausal and are with high risk of relapse that are patients that receive chemotherapy at adjuvant treatment, and also the patients that are younger than 35-year-olds, we demonstrate that ovarian suppression with aromatase inhibitor for 5 years improved the survival of this patient. Now, and this is one of the standard of treatment in this patient. But of course, we have a lot of side effects about this ovarian suppression. And in postmenopausal patients, there is a meta-analysis that was present 2 years ago in San Antonio with this International Breast Cancer Symposium. And we demonstrate that for patients that have high risk of relapse, that are patients, we have 4 or more axillary lymph nodes affected, that prolonged hormonotherapy for 10 years improved their survival. But also these patients have side effects like risk of bone fracture and another side effect that we have to take in account when we select to give the patient 10 years of treatment. About chemotherapy, the most important treatment in early breast cancer is anthracycline and taxane, but in the last year we introduced also carboplatin and capecitabine to treat triple-negative breast cancer. Here is what we usually use to treat early breast cancer, that are 4 or 8 cycles of anthracycline and taxane, and as I told you, also platinum for triple-negative and capecitabine in those triple-negative breast cancer that didn't get pathological complete response after neoadjuvant treatment. And also we have a lot of biological treatment. To treat early breast cancer, we use trastuzumab, pertuzumab, T-DM1, and neratinib. The most important of the drug that go to HER2, that are trastuzumab and pertuzumab, that are antibody that goes against the HER2 receptor. And in the last year, we introduced T-DM1 for this patient that are HER2 positive and didn't get a pathological complete response after neoadjuvant treatment. T-DM1 is a conjugate antibody that's put together the antibody and the chemotherapy. So trastuzumab linked to the HER2 receptor and introduced the chemotherapy only in the breast cancer cell. So we have a lower side effect for this patient. This is what we use to treat HER2 positive early breast cancer that has been talking about. And we hope in the next few years we can introduce immunotherapy to treat early triple-negative breast cancer. So this is all the different type of systemic treatment that we use to treat breast cancer, and of course we will take in count without the side effect of this treatment in our survival of breast cancer patients. So thank you very much, and I hope the next time we can see in person in Valencia, and see you soon. Thank you.
Now we would like to ask you to please rate this session from 1 to 5 stars. I would like to introduce you now to Professor Margaret Rees. She's going to speak about gynecological cancer.
Good morning. I'm going to be talking about gynecological cancer and to explain that all cancers are not the same, and this means that their management is different. So worldwide, 1.3 million new gynecological cancers are diagnosed each year, and there are different types: ovarian, uterine, vaginal, vulval. They will present at different stages, some late, such as high stage serous ovarian tumours, others early, such as endometrial cancer. And some may be hormone dependent. This means that different treatments are used. This can be hysterectomy with or without bilateral salpingo oophorectomy, radiotherapy, chemotherapy, and anti-estrogens. Some cancers occur in young women, leading to premature menopause, and their management needs to be individualized based on the type, stage, and hormone dependence of the tumor. So going through specific cancers and starting with endometrial cancer. Most endometrial cancers are diagnosed at an early stage, and they tend to be diagnosed after the menopause and have a good overall prognosis, with a 5-year survival rate of over 85%, and the treatment is surgical. Looking at the studies of HRT, menopause hormone therapy, MHT, they are limited in terms of numbers of randomized controlled trials and observational studies. But a Cochrane systematic review concluded that MHT is a reasonable option for patients who are at low risk of tumor recurrence, i.e. early stage. But the evidence is limited. There is no evidence about higher stage disease, and there are no studies available for women with Lynch syndrome who are also at increased risk of other cancers such as colorectal, breast, and ovarian. Gynecological sarcomas may be hormone dependent, and therefore estrogen and progesterone receptor testing should be undertaken to guide decisions as to whether MHT can be used or not. But the proviso is that there are no data regarding MHT in non-hormone dependent tumors. And then there is a new entity, which is smooth uterine muscle tumors of uncertain malignant potential, STUMPs. These are tumors which may recur and are neither leiomyomas or sarcomas, but in between. And there are no data about MHT. Coming to ovarian cancer, there are 3 major types of ovarian cancer. These are epithelial, germ cell, and sex cord stromal. Fallopian tube cancer, primary peritoneal cancer, and epithelial ovarian cancer are now considered to be indistinguishable and share the same genomic signature. So the treatments for these cancers are the same. There are 5 types of epithelial cancers. So high, these are aggressive grade serous carcinomas, low-grade serous carcinomas, endometrioid carcinomas, clear cell, and mucinous. And the different histotypes are now considered to be different diseases. So, low-grade serous, what about MHT? It is currently not recommended for this type of cancer of the ovary or peritoneum in advanced disease, because the treatment is anti-estrogen therapy with letrozole, anastrozole, tamoxifen, and leuprolide acetate after surgery and chemotherapy. And there is no evidence to inform practice about high-grade serous disease. What about non-serous tumors? So MHT either systemic or topical, does not seem to be associated with harm and does not appear to decrease overall disease-free survival. But the proviso is that the data are limited. The regimen depends on whether a hysterectomy has been undertaken or not. Germ cell tumours tend to affect young women, so often fertility-sparing surgery will have been undertaken. So the balance of whether to use MHT or not depends on the risks of early menopause versus the risk of recurrence. But these are good prognosis tumours. Granulosa cell tumours are the most common sex-cord stromal tumours, and they affect, again, young women. But they also secrete sex steroids, and they can recur up to 20 years after diagnosis. So recurrence therapy includes aromatase inhibitors, but there are no studies which show that MHT show harm. So in women with a premature menopause, one has to balance risks between the risk of premature menopause and the risk of recurrence. Cervical, vaginal, and vulval cancers are not hormone dependent, and the regimen, estrogen alone or combined with progesterone, depends on whether hysterectomy has been performed or not. Then there is a group of women who were exposed in utero to diethyl stilbestrol. This was a medicine used in the 1950s and up till 1978 to reduce the risk of miscarriage. And these women are at increased risk of clear cell tumours of the cervix and vagina. And we have no evidence regarding the safety of MHT use. For further information, you may wish to read the position statement, which was written by EMAS and the International Gynecologic Cancer Society on managing the menopause after gynecological cancer. And the focus was on symptoms and osteoporosis. And this paper is open access. Thank you very much for your attention.
Now we would like to ask you to please rate this session from 1 to 5 stars. I would like to introduce you now to Professor Ludwig Kiesel. He's going to speak about endometriosis, another significant contributor.
So welcome to this next lecture of the EMAS School. I welcome you here from Münster, my hometown. And my topic is on endometriosis, which is also another significant contributor for the changes of ovarian function, either due to the disease or due to the treatment. As you can see in this slide, endometriosis is a complex disease where the growth of endometrial tissue can be in different places, and it's rather common. It's a benign condition, and it can be up to 10% of women, and it's a frequent cause for unspecific menstrual cycle-dependent pelvic pain or even independent of the cycle. And it's generally estimated that around 30 to 40% of women with endometriosis may not be able to have children. So it's a significant problem, and would like to talk about this disease and how we can manage some of the problems which occur following treatment. Now, there are various treatment options for endometriosis, And generally, there are two groups. The implants of endometriosis can either be removed surgically, which is shown down below, or by various medical treatments. And both of these treatments may have some effects, not only on the disease itself, but also on the ovarian function and also on long-term consequences. So medical treatment is in general related to the hypothalamic pituitary ovarian axis, interfering with the production of estrogens. That's the one option. Or you can actually directly inhibit the action of estrogens at certain level, such as by giving progestins. So there are different ways of interacting with the endocrine-related progression or implantation of the disease. Now, there is quite a long list of different options which are generally used, and this is a range which is from analgesics, non-endocrine treatment, but most of the others are endocrine treatments, just as GnRH analogs, which will block the pituitary ovarian axis and thereby reducing estrogen synthesis, causing, of course, estrogen withdrawal. There are other substances which are very commonly used, are progestins or oral contraceptives. And in former times, danazol has been used as well. In certain circumstances where endometriosis is in the wall of the uterus, IUDs, usually loaded with levonorgestrel, can be helpful to treat that disease. In certain cases, aromatase inhibitors can be useful, and this is usually done in postmenopausal women, a very rare disease, and it can interfere with the local production of estrogens within endometrial implants. If you take the two important methods to treat endometriosis medically, is either Dionagest, which is shown with the blue dots, and one GnRH analogs as shown here. And as you can see from here, both agents are about the same when you look at reducing pain. So VAS score is a visual analog scale, as you know, will reduce pain over the treatment period of 6 months. And there is no big difference between the two agents. We think that progestin action and oral contraceptive action is probably also in that range. And these are the common drugs used. But there are major differences in the different countries, as you can see in this slide. There has been a study looking at different countries, which treatments are given to women. And as you can see here, there are differences when you use Dionagest, which is abbreviated with DNG, or GnRH analogs. And there are different numbers, as you can see, and also oral contraceptives, like Switzerland having 11%, whereas Hungary 84%. So it's not just the medical way of decision-making, but also some other reasons. Now, if you use GnRH analogs, which used to be the gold standard for many years, there is a rather sharp drop of estrogen production after about a week of flare-up. And you all know the use of GnRH agonists, but also of antagonists, to reduce estrogen production. Now, this drug, of course, has a major effect on estrogen withdrawal, which is helpful for treating endometriosis, but it will have other side effects, such as on the bone function, but also on symptoms like menopausal symptoms. So you actually put women transiently in a postmenopausal state. So this cartoon shows you a hypothesis that actually it's not absolutely necessary to reduce totally ovarian function, but you can add back some estrogen and progesterone, so you can go into a higher zone. So coming from zone A, you don't have to be in zone C in order to treat endometriosis, but zone B, which is sufficient, and therefore you may have less symptoms and side effects. Now, the same problem can occur with surgery when you operate on the ovary. So the effects of surgery on the ovarian reserve can happen. As you can see in this graph, you can see that the ovary on the left side holds a big endometrioma, and this and all the other implants will interfere. So when you remove that cyst and you have to coagulate because of bleeding, etc., you may burn all the oocytes which are in the ovary and also produce and in the follicles producing estrogens. So you may end up burning all these follicles and reduce also estrogen production. So if you look at a marker, which is AMH, anti-mullerian hormone, it is a good marker for ovarian reserve. And you can see in this graph that in the left column, endometrioma group, there's a reduction of AMH after operation. And not much of that occurs if tubal surgery is done. Some of it can occur with other cyst operations as well. And the other interesting thing is that usually AMH is somewhat lower in the endometrioma group. So you may have some effect of endometriosis on the ovarian reserve by the disease itself, but also by the surgery. So that's something very important to understand. Now you can see in that graph that if you look at patients who've been operated on endometrioma, there are a remarkable change or decrease of age at menopause. So if we take in Europe, we have about 50 or 51 years. And if you look at just endometriosis, which has also some effect, it is usually lower. And mainly if you operate on endometrioma, bilateral endometrioma, you will have even more. So you have quite early menopause or even premature menopause. And endometriosis itself, even in a mild form, there is some effect on the age of menopause. And we think that the way you treat the ovaries for endometrioma may be important. So ablative surgery can be a problem, and also excision of surgery. So maybe one has to be very careful not to reduce ovarian reserve by having this surgery done. Now the question is, what can we do to prevent premature ovarian failure? And one aspect is fertility preservation. It's not just for the endocrine reason, but mainly for fertility. And as you can see in this graph, AMH levels can be very different. PCO generally is high, and then these are normal values. And in endometriosis, as shown before, we can have low AMH values. So the problem with endometriosis is that it can recur, and surgery may have to be repeated. So it is advisable to think about some fertility preservation by having some of these parts of the ovary to reserve it for later time, because if repeat surgery is done, maybe there will be no ovarian function left afterwards. So that's shown here, that AMH level can drop very, very much. So patients would benefit if during endometrial operations or other surgeries, you would think about these options, and there will be a further lecture on that topic. But of course, it's important to look at other factors, age and AMH levels by itself. Now, why is or why are we talking about this early menopause, premature menopause in women with endometriosis. Now, this study performed in a hospital and published this year looks at the surgical menopause. So in cases where you have actually removed almost the ovaries themselves, or you actually did oophorectomy on both sides, and that's called surgical menopause. So if you look at the indications why it has been done, you can see that in that hospital where benign surgery and also malignant surgery has been done, you can see that quite a remarkable amount of women have undergone surgery due to pelvic pain or endometriosis, ending up having no ovaries afterwards. So that's an important issue, and we have to think about how we can help women to get over their problems apart from endometriosis. So you can see on that summary that women with a history of endometriosis who may end up having symptoms and also other problems, we have to think about hormone replacement therapy. So women who become climacteric due to surgery, for example, have to be counseled with regard to treating their symptoms. Now, there are some issues about it before I go into that. Some issues are about the possible reactivation of residual endometriosis even after menopause if women receive hormone treatment. The question is there even new implants somehow when you give HRT? And the question about malignant transformation is still not quite clear, but it appears that all three aspects are not so important as the other consequences, which are shown below, which are premature or early menopause with a reasonable risk of overall mortality, cardiovascular disease, dementia, osteoporosis, etc., what we are talking about here. So there is a need of thoughtful HRT management in women who have lost their ovarian function at early age. Now, EMAS has summarized all the recommendations which may be helpful to give HRT treatment to women. And you can see here that women do require replacement therapy if they are premature or in early menopause, and also older women with severe climacteric symptoms. And that's obvious from the first slide before, that all the other very important diseases can have an increased rate in endometriosis patients per se, but also due to premature ovarian function and decrease. And usually we suggest continuous combined estrogen and progestin therapy or tibolone, both for hysterectomized and non-hysterectomized women. And that's a big difference to others because that's usually different. In hysterectomized women, you usually wouldn't give progestin, but we do give that. So if you are interested, look up that EMAS statement, or you can go also in ESHRE where there is more on endometriosis itself, because I hope you could see from that slides that endometriosis can become a complex disease to treat, but also some consequences which we have to consider in these patients. Thanks very much.
Now we would like to ask you to please rate this session from 1 to 5 stars.
Now, we would like to present the next session, Interactive Debate, presented by Professor Angelika Linden-Hirschberg.
Thank you for your attention. Now you will have the same 3 questions with 20 seconds each. The results of the selections will be shown and will be checked whether the knowledge has been improved. So please pay attention to the questions.
Good afternoon, everybody, and welcome to this interactive debate session. I hope you enjoyed the presentations and the test with multiple choice questions. I would like to start to comment the results. And as I could see, the level of knowledge was in general very high in this audience. But anyway, in my opinion, it was clear that the learning outcomes were very good. Okay, so now we will start this interactive debate session with the younger doctors as participants. And I believe that they have prepared some questions. And I wonder if Dr. Botas would like to start.
Hello. Unfortunately, we've had some problems with our connection and I couldn't hear all the discussion. But I would like to ask a question to Dr. Bermejo.
Okay.
Is that possible?
Yeah.
Hello. I'm Ioannis from Greece. And thank you for your presentation. I would like to ask you if there are new challenges in the treatment of early breast cancer in terms of neoadjuvant chemotherapy or anything else.
Sorry, I have to interrupt. Those who are not speaking, please mute your microphone.
Okay. Hello to everyone, and thank you for the question. Yes, of course, the most important thing we are trying to improve, as I was talking in the presentation, is to improve the survival. But a part of the survival, we have to improve in the side effect of the treatment that we give to our patient. As I show you in the presentation, for example, in the subgroup of patients with luminal breast cancer, right now we can avoid chemotherapy with the genetic platform, and I show you in the presentation. So we have been able to avoid a lot of side effects that chemotherapy gives to our survival patient with breast cancer. But in the same way, for example, for the HER2 positive breast cancer patient, we are trying also to avoid chemotherapy and just only give them biological treatment against HER2 receptor. And in this way, in 2 weeks, and in ASCO Congress that used to be in Chicago, but we are sure that it's not going to be in Chicago. We will do in the same way that we are doing this Congress. A Spanish group is going to present the result of a trial where we select a subgroup of patients with HER2 positive with the TAC PET, and where we demonstrate we are able to avoid the chemotherapy and we get a pathological complete response, yes, only with biological treatment. Mm-hmm. And in that way, I think we also, in the last 10 years, with the use of sentinel lymph node, we avoid the axillary lymph node dissection, and in that way we avoid the lymphedema. And also with the radiotherapy in the situation that is with the pandemic in all the world. For example, in Spain, we change the radiotherapy treatment, and we do an hypofractionate treatment, and instead of 3 weeks of treatment, we just give the patient 1 week. So I think in that way, one of our efforts is going to avoid all the side effects that our survival patient with breast cancer have.
Can I ask you one more thing, please?
Sorry?
Can I ask you one more thing? Is
Yes,
there
of
any
course.
difference in young patients or in after menopause patients?
If they are different with
Yes.
treatment?
With the therapy, yes.
Well, it's not really, because what we know that what is the most important thing to determine it, which is the best treatment, is the biologic of the breast cancer. It's
Okay.
true that, as I show you in the soft trial, we demonstrate that to give ovarian suppression with aromatase inhibitors, it's improved survival just in the patient with a younger than 35 years old. But if you look the result of this trial, you will see that more than 19% of the patients that are younger than 35-year-olds, all of them receive chemotherapy. So this is why we have the result, maybe because we decided that this patient biologically have a more aggressive tumor. But in our clinical practice, I have a patient that is very young, and for example, I do the patient and genomic platform, and I have the result that is a very low risk of relapse. I also avoid chemotherapy in this patient. And in the same way, with the trial that I told you that we are going to present in ASCO, I have two very young patients that didn't receive chemotherapy, yet only biological treatment, and they get a pathological complete response. So I think the most important is not the age, it's the biological of the breast cancer.
Thank you.
Thank you so much. Maybe Dr. Nigdelius will continue. Do you have any question?
So yes, thank you so much. Thank you so much for the great meeting. We had some problems connecting. We're moving on to the next topic, if I'm not mistaken. Right, Professor Hirschberg? Okay, good. So endometriosis is a very, very important topic, as we just realized, for premenopausal, postmenopausal patients. Professor Kiesel from Germany showed us very interesting data. I would like to pose the question, what are the potential mechanisms through which endometriosis might affect ovarian function and could thus probably cause a premature ovarian failure? Thank you so much.
So, as I pointed out, there are radical surgery may affect ovarian function, which is obvious if you remove the ovaries. But also there are some hints that if you have endometriosis in the ovary, I think now you can see me on the screen, you can also have some limitation of the ovarian function per se by the endometriosis itself. So we think that both surgery plus endometriosis will inhibit ovarian function, and we have to be very careful how we deal with it. And there are also indirect effects, let's say distributed endometriosis within the pelvis. So like peritoneal endometriosis seems to have some effect on ovarian function, and women who have endometriosis enter menopause much earlier. So there seems to be numerous ways how you can interfere with ovarian function, which is important for fertility, obviously, but also for perimenopausal and postmenopausal women. So I think this is one important link towards similar things as in oncology. And there is also some link to oncology via ovarian cancer. So there's a higher risk of development of ovarian cancer in endometriosis patients. Not a high risk, but it's a reasonable risk one has to consider. Thank you.
Okay,
Thank you for the wonderful answer.
some more questions about endometriosis?
Hello, my name is Crețoana, and I have a question to Professor Kiesel, if it's possible.
Yes, okay.
What should we consider to prevent ovarian failure in women with endometriosis?
So as I said, there are numerous ways how it can interact. So one of the main reasons we ask surgeons to be very cautious is just to remove endometriosis tissue and leave behind as much ovarian tissue as possible. That's possible if you are very careful, but also if you don't use much coagulation. Because if you coagulate tissue, obviously you destroy a lot of tissues which are benign, so non-endometriotic tissue. So like yesterday, did a surgery on a woman who had several endometriosis operations of the ovary, and the ovary on that side, which had endometrioma, was much, much smaller than the other one. So it actually shrinks, which you can't even see during surgery because cauterization has a long-term effect of destruction of endometriosis. So that's one thing. And the other thing is probably if you remove endometriosis elsewhere, it may affect ovarian function as well. So prevention can be good surgery and also removal of as much endometriosis as you can without destroying good tissue. So that would be a good world if we can achieve that. Thank you.
Thank you very much. Sorry, thank you very much.
Thank you so much. Who wants to ask a question to Professor Margaret Rees? Perhaps Dr. Botas, do you have any question?
Yes, thank you. I would like to ask you if the unopposed estrogen in the menopausal hormone treatment can be used in women with cervical cancer treated with chemotherapy or radiotherapy or together.
Thank you very much for the question. The answer is, if the uterus is intact, they must use estrogen plus progesterone, because there is no assurance that chemoradiotherapy will ablate the endometrium. And if you give unopposed estrogen, it would increase their risk of endometrial cancer.
Excuse me, did you hear the answer? For me, there were some echoes and difficulties.
Yes, I could hear. Thank you.
Okay, good. What about Dr. No, let me see, Dr. Dirlau, do you have any question?
Yes, thank you. I have a question for Professor Rees too. What should be discussed with an 18-year-old diagnosed with a germ cell ovarian tumor who has undergone fertility-preserving staging surgery, followed by platinum-based combination chemotherapy?
The main issue to discuss, because it is a good prognosis tumor, is the risk of early ovarian failure, which leads to premature menopause and also to infertility. Therefore, she needs to know about the use of HRT. Then it's a question of should she be discussing fertility conserving strategies like egg freezing. But the other thing she needs to think about is that she may want to plan her pregnancies and that she should be considering the combined oral contraceptive pill. So the range is fertility, contraception, and menopause.
Thank you very much.
Thank you so much. Do we have other questions? Who wants to ask?
I have a question to Professor Rees. Are there experiences of patient support groups in women surviving any sort of gene cancer? And may they have any interest? Which, if any, has been the reported results? Thank you.
I'm sorry, I have a problem with the echo, and I will come back to you once I have all resolved it.
Okay, do we have another question to some of the other professors? For instance, about breast cancer. Do you have another question?
So may I ask Dr. Bermejo a question, Professor Hirschberg? So if we want to concentrate on the short-term period that you mentioned prior to definitive cure, how does surveillance look like? So what should we do to monitor and conduct a proper surveillance to these patients? After all, one should ask, are we actually over-controlling? And if we wanted to take a step further, we would probably want to ask ourselves, how long should the surveillance be prior to deciding on a definitive cure for these patients? Thank you so much.
Well, it's true that for breast cancer patient, we need to follow the patient for all their life. This is true because at least I think in Europe, and when the patient is diagnostic of breast cancer, they go out of the screening program. So someone needs to make a mammography to this patient. What we are doing in Spain is trying to make a program where the doctors that are working in the primary medicine, they are doing the following of this patient, and we are trying to have a program where during all the following we can make together this follow with the patient. Yes, not only thinking about the survival of the patient, yes, also with all the side effects that this patient can have in connection with hypercholesterolemia or high tension, hypertension, or for example, in our hospital, we are very lucky because we have Dr. Cano with us, and we have a program where the gynecologists follow all the side effects like osteoporosis and all these things. And we are trying to share the following with these different specialists. So the oncologists only need to see the patient once a year, something like that. So we don't need to put this patient in a continuous following with different specialists. We are trying to make a better program to follow this patient.
May I follow up? Just a short question on that?
Absolutely.
If time allows. So this
One more minute.
Okay, great. So this is great what we just heard, because it basically transforms the way we see the breast cancer patients. Did you have any feedback from the patients themselves? Do they feel good with that? Is it better? So could you give us some hands-on experience, so to say?
Yeah, because I think the breast cancer patient, at least in where I live, they have a very close connection. We have a very close connection with the doctor and the primary medicine, because they also can get in contact with us very quickly if they have any doubt about the patient. We can see the patient in 48 hours, in 2 days, or even the next day. So the patient feel comfortable like that, because they know that if there is any problem, or if the primary doctor have any doubt, we will see the patient, yes, in short time. So our experience is, it's very, very, very good. And of course, we have a lot of survival patients with breast cancer. We need more time to dedicate the patient that have are metastatic, or they are on treatment. So it's our experience is very, very, very good, and we hope we will be able to do it even better in the next years.
Thank you very much.
Thank you.
Thank you so much. I think Professor Margaret Rees is back now. So we make another try. Who wants to ask a question to her?
I'm going to repeat my question. I hope that Professor Rees resolved her problem. Professor Rees, are there experiences of patient support groups in women surviving any sort of gynecological cancer? And may they have any interest? Which, if any, has been the reported results? Thank you.
Are you talking to me about the estrogen receptors in granulosa cell tumors? I would say that we have no evidence that they can't be given HRT. So that is the problem. It's his lack of evidence, but we have no evidence to the contrary.
Is there any follow-up question on this subject from anyone?
Thank you very much, Professor Rees, for your answer.
Okay, I think we have some questions from the audience, and we have a couple of minutes left. So we could start with the first question. Given expected 53% increase in endometrial cancer, is it time to consider a screening monitoring program for high-risk groups such as PCOS? Maybe this is a question for Professor Margaret Rees, please.
Unfortunately, we have no data, so we can't say one way or the other. But if somebody who has PCOS and has abnormal bleeding, one would be more alerted to the risk of an abnormal endometrium. The same thing for somebody who is overweight or obese.
Okay, I certainly agree. We could move on to the next question. Some of the IVF centers asks for surgery before any IVF on women with endometriosis. Now it disappeared for me. If patient has mild endometriosis, and there it is back again, Some of the IVF centers ask for surgery before any IVF on women with endometriosis. Do you think that this should be changed? I think this is a question for Professor Kiel, please.
Yes, this is a long ongoing debate, how much surgery patients actually need before you do IVF. There are radical ideas of saying you don't actually need any surgery if you do IVF. And the other saying is that you have to check many other things, including endometriosis. So one aspect, which is endometrioma, has been very well examined. And if you want to look it up in the ESHRE guidelines, there are some ideas how to go about this. Earlier days, we removed every endometrioma before going for IVF, but now for several reasons. One is what I did say today, to prevent removing good parts of the ovary. And the basic finding was that pregnancy rate did not change that much if you removed endometrioma, as long as it is not bigger than 3 to 5 centimeters. So there is a debate on the size of the endometriosa and if you should do it at all. Of course, if patients have major complaints, having endometriosis symptoms, then you will have to do it. But if patients do not have any symptoms and you just see it, it is not really advisable to remove all these endometrioma tissues. So that's what we think today. So it's different what we think today than we did before. So the question about minimal endometriosis, and now it looks like that minimal and minor cases, you have some influence on fertility. But if you do IVF, it may be not that big difference. And the most studies actually do not show a great difference. There are some studies showing even in mild endometrioma some effects on ovarian quality, but pregnancy rate itself may not be that different. So no major surgery is recommended unless patients have symptoms or the endometrioma are too big, or you can't puncture the ovaries because the endometrioma is in the way in the ovary. So unless there are practical things, you don't actually have to remove smaller ovarian endometriomas.
Thank you so much. I think we have time for one more question, and we can continue with endometriosis, if we will get a short answer, hopefully. If a patient has mild endometriosis and was operated a few years back and is asymptomatic, can she have only estradiol HRT instead of combined HRT?
Well, the problem with this answer is that in most cases you didn't distinguish between the different stages and the different types of endometriosis. So I think, of course, if patients do not have a severe type of endometriosis, which is aggressive on bowel or bladder, etc., you may give just estrogen if the patient, of course, has no uterus anymore. But of course, otherwise you have to give progestin as well. Thanks.
Okay, thank you everybody so much. I think this was an interesting debate, and now it's time for coffee break. So thank you so much and hope to see you later. Okay, bye-bye.
Welcome to the next session. Before the speakers start their presentations, we would like to explore the knowledge of all the attendees. We have prepared one multiple-choice question for each topic, and you will have 20 seconds to give your vote. Please don't forget to click on the poll tab on the right side of your screen.
I would like to introduce you now to Professor Maribel Acien. She's going to speak about drug-mediated, cytotoxic drugs and endocrine regulators.
Good afternoon. This talk is about drug-mediated early menopause, and for that, we will briefly talk about cytotoxic drugs, endocrine regulators, and the quality of life consequences of this treatment. The most common types of cancer occurring between 15 and 39 years include lymphoma, melanoma, cancer of the male genital system, cancer involving the endocrine system, and cancer of the female genital tract. Cytotoxic drugs have an impact on reproductive potential, which depends on the age of the patient, but also the type, dose, and duration of treatment, and also characteristics of the individual who is suffering the cancer and the cancer itself. In general, the adult women will have the possibility of offspring particularly low, but especially if they suffer an hematological or breast cancer, being in this group, the chances of having an offspring decreased over 70% when compared with the general population. Cytotoxic drugs can be subdivided by their risk of provoking permanent amenorrhea, and for that, therapeutic regimens, including cyclophosphamide, are of high risk. These cytotoxic drugs can also be subdivided by their infertility risk, and for that, busulfan, cyclophosphamide, chlorambucil, and procarbazine are of high risk, but also polychemotherapy regimes, including cyclophosphamide or some other ones which are used for women over 35 to 40 years, are also of high risk. Endocrine regulators are used to counteract a patient's own hormone production when a patient is suffering a hormone-dependent tumor. Tamoxifen is a SERM with an estrogen receptor antagonist at breast action, with an agonist at cervix and vagina action, and characteristically also an estrogen agonist action on the endometrium, especially if the woman is postmenopausal, which means they have an impact on of endometrial cancer. Aromatase inhibitors will act stopping the conversion from androgens to estrogens, and they characteristically have no change or even a reduced risk of endometrial cancer. And the GnRH analogs, which are mainly used, are agonists, being goserelin and triptorelin. In gynecology, we use these endocrine regulators, especially for breast cancer patients. If the patient is premenopausal, mainly tamoxifen is first option, but if the patient has risk factors, then aromatase inhibitors with analogs is to be considered. Whereas on the contrary, if the patients are postmenopausal, then mainly aromatase inhibitors are being used. But if these patients have low risk characteristics, then tamoxifen can be considered. So all these drugs have an impact on fertility and menopause symptoms. We've already mentioned that chemotherapy has an effect on ovarian reserve, and we have to know that the use of analogs during that chemotherapy reduces the risk of premature ovarian insufficiency. We also have to know that tamoxifen, when used for a long treatment, has a deleterious effect on the endometrium with no effect on ovarian reserve. Regarding sexuality symptoms like vulvovaginal atrophy, dryness, dyspareunia, or reduced libido, in postmenopausal women, and aromatase inhibitors have a stronger effect, deleterious effect of these symptoms, stronger than when tamoxifen is being used. And also with aromatase inhibitors, there's an increased risk of fecal incontinence. Hot flashes are stronger in premenopausal women when on treatment, chemotherapeutic treatment or analogs are being used compared to when tamoxifen is being used. Whereas in the postmenopause, tamoxifen has same frequency of flashes as when aromatase inhibitors are being used. Musculoskeletal symptoms are present in about 50% of women under aromatase inhibitor treatment, especially if they have been treated before with a taxane-based chemotherapy. And this is due to estrogen deprivation, but also fluid retention and tenosynovitis effects. So to retain the fertility, or at least an intended fertility retainment, egg harvesting and cryopreservation are recommended without delay for the treatment of their cancer in good prospect patients regarding their cancer, but also regarding their chances of cryopreservation based on the antral follicle count. We have to know that there's no negative impact on the cancer due to these stimulation protocols. And in fact, in breast cancer patients, aromatase inhibitors are being used to avoid high levels of estradiol. Once the chemotherapy is finished, we have to also remember that having menstruation does not mean that the patient is ovulating, or remaining amenorrheic does not mean that the patient is infertile. And for that reason, barrier methods or IUD are recommended for a minimum of 2 years after chemotherapy. Once the patient is, so said, cured, pregnancy can be allowed even in women with hormone-dependent tumors, since no impact on recurrence has been proven. But regarding the menopausal symptoms therapy, we have to say that hormone replacement therapy is relatively contraindicated in certain cancers as leiomyosarcoma and certain ovarian tumors of endometrioid and granulosa cells, brain tumors, advanced malignant melanoma, lung cancer, gastric cancer, and bladder cancer, and it's considered in general disadvantageous in patients suffering breast cancer, endometrial stromal sarcoma, meningioma, glioma, or hormone receptor positive gastric and bladder cancer. So for these patients, in general, we may say that to treat their menopausal symptoms, some recommendations can be given. So for the vulvovaginal atrophy, vaginal moisturizers and lubricants are to be used in first line. For the sexual dysfunction, then psychosexual counseling, the use of vaginal dilators, pelvic floor relaxation techniques, and support for the body image concerns arising after breast surgery or treatment-induced hair loss is highly recommended. For the hot flashes, first line is treatment with non-hormone alternatives. And for the arthralgia due to aromatase inhibitors, we have to say that pharmacological, acupuncture, and relaxation techniques have proven low evidence, whereas hypermobilization, yoga, and weight loss should be recommended at first line. But we will hear further on these topics on the next talks. So I thank you for your attention.
Now we would like to ask you to please rate this session from 1 to 5 stars. I would like to introduce you now to Professor Francisco Quereda. He is going to speak about surgery, the actual role of salpingo ovariectomy.
Good afternoon. First of all, I would like to thank Professor Cano for his invitation because it's a great pleasure for me to be here. He asked me to talk about the actual role of salpingo ovarectomy in the context of a woman living with and beyond cancer. I have no conflicts of interest on this topic. Well, I would like to start thinking about why do we perform bilateral salpingo ovarectomy. Of course, to treat ovarian pathology, but also to prevent ovarian pathology, and in the past, but sometimes nowadays also, in the management of non-ovarian malignant disease. For ovarian pathology, the main indication is treating malignant disease, or many times suspicion of that. But sometimes treating benign pathology, some cyst or previous ovarectomy, unilateral ovarectomy, could mean the same aim. In the context of ovarian pathology prevention, it could be done to avoid recurrent benign ovarian disease, like is the case of endometriosis, most of times during the treatment of present endometriosis, but trying to get avoiding recurrent benign ovarian disease in the future. But other indication is to prevent ovarian cancer in high-risk women, and it's called, in this situation, risk-reducing salpingo ovarectomy. And the other very frequent opportunistic salpingo ovarectomy is during surgery for other non-ovarian indication. For example, hysterectomy for uterine myomas. Finally, the management of non-ovarian malignant disease. In the past, we know that for treatment of some breast cancers, and nowadays also in some cases, or to prevent breast cancer, is necessary. Don't forget that throughout bilateral salpingo ovarectomy, we can get a reduction of breast cancer almost 50%, and it was the basis for the development of antiestrogenic therapy for breast cancer. But we must consider that we could be in two scenarios when bilateral salpingo ovarectomy is going to be done. One for premenopausal women, another for postmenopausal women, and it's not the same. For premenopausal women, we are going to induce, of course, sterility, but also an abrupt hormone deprivation and greater than in natural menopause. And for postmenopausal women, we are going to add a certain additional androgens deprivation with respect to natural menopause. If we see this figure, we can compare the great reduction in hormone levels, more for estrogens than androgens, and how this is in natural postmenopause, and it is very abrupt in a surgical menopause in the premenopausal women. But for postmenopausal women, surgical menopause adds a certain higher decrease in androgen levels. If we look some data, for example, from USA of 2010, we can see that more than 600,000 hysterectomies were performed for benign disease. And within them, elective bilateral salpingo ovarectomy was performed almost 45% of women aged between 45 and 49 years old, which is premenopausal for most of them, and almost 23% between their 40 and 45 years age. So very young people. And if we look at the reasons for surgical menopause, for example, from Diana study, a transversal cohort epidemiologic study at Spain, we can see that in the reason for surgical menopause, almost 50% was done for during hysterectomy for leiomyomas, which is debatable at least. And for endometriosis, almost 19%, and for dysfunctional uterine bleeding, another 17%, and only the most clear indication, which is oncological reasons, almost 15%. If we keep in mind that the impact of hormone deprivation depends on the age and is important, like next speakers today and tomorrow are going to tell us, and I'm not going to enter in this area, but it's important. I only want to highlight the most important repercussion, which is mortality. Now it's known that the younger the age when bilateral salpingo-oophorectomy is performed, the greater a negative impact on mortality is going to suffer these women. An example of that, you can see if look at this figure where I'm showing you a comparison of cumulative incidence of cardiovascular disease, but it's the same for mortality, during follow-up between placebo groups from WHI trial arms. If you see between these women from both arms, the main difference was to be hysterectomized, and most of them including bilateral salpingo-oophorectomy. If you see the figure, you can see the higher mortality of the group of women with bilateral salpingo-oophorectomy versus the other. So many papers have shown us this finding. So in this context, we might keep in mind that when we are thinking about bilateral salpingo-oophorectomy, there are benefits that we are looking for, but we are introducing some risks that could be important. So it's necessary to review the possible goals that we can have if we are thinking about performing bilateral salpingo-oophorectomy. First of all, removal of malignant tumoral tissue, and is no question about that. Also, removal of possible microscopic metastases, and in this case, depends on a probability, and for some kind of tumors and for younger women, it's possible to preserve ovarian tissue to avoid the deprivation. Other possible goal is histologic diagnosis of ovarian tumor, and we must think that we have the possibility of intraoperative biopsies or other things to avoid the bilateral salpingo-oophorectomy if it is unnecessary. And for treatment of ovarian benign disease, we must think always that this is the only way that we must go. And in the chapter of prevention or recurrent or new incident ovarian pathology, the case of benign or malignant, we might differentiate two populations. First, high-risk population, BRCA mutation carriers, for example, which is a very increasing surgical indication, and is correct, but I'm going to talk about that in next slides. And general population, where like performing BSO during intervention, during a surgical intervention for benign ovarian pathology or other indication for surgery. And you can see that I put it in red color because we might think about that. If we look some data on BRCA mutation carriers, comparing to general population, you can see, of course, how they have a great increase in the ovarian cancer lifetime risk, and it's not the same between these two groups. And of course, also a very great increase in breast cancer lifetime risk, and how the recommendation is for this group risk reduction salpingo-oophorectomy be performed between their 35 40 years after they have their wanted children, if possible. And for BRCA2 carriers, this recommendation is delayed more or less 5 to 8 years later, because for this population, we know that ovarian cancer usually appears between 8-10 years later than in this other population. Another difference is that the breast cancer of this population usually is triple negative cancer, and in this population usually is more frequent hormone-dependent cancer. And all of that is related if we keep in mind that we are getting an overall mortality reduction after risk reduction salpingo-oophorectomy around 60%, significantly 60%. But if we look that if we compare overall mortality between non-users and users of HRT after the procedure, I would like to highlight that non-users had 40% increase in mortality after versus HRT users after BSO. And what is the thing in the general population at younger age? There is no recommendation for risk reduction salpingo-ovariectomy because overall mortality is increased between 10 and almost 70%. And if we look at after the procedure and we compare non-users of HRT after the procedure between versus users of HRT, we can see an increase of overall mortality near 10%, near twice. So it's an important matter, and a very recent ECO committee opinion has told us that perhaps we would think about the possibility of getting the risk reduction or very valuable risk reduction only throughout salpingectomy, and for some cases, interval salpingectomy and delayed ovariectomy as an alternative for the future for some women. But it's not clear, it's unclear today, and there are some trials ongoing for those matter at this moment. So what we might do today and after, sure, is previous advice, keeping in mind everything I have been talking about, and an individualized approach to take decisions. So if we would like to see not only swans, but besides elephants, like in this very known picture, we must keep in mind that bilateral salpingo-oophorectomy and risk reduction salpingo-oophorectomy have beneficial but also detrimental effects on women's quality of life, but also on life expectancy. This may be kept in mind during management and before taking decisions, and HRT use might be considered, if possible, for younger premenopausal women because it implies reduction of mortality in this setting. Thank you very much.
Now we would like to ask you to please rate this session from 1 to 5 stars. I would like to introduce you now to Professor Nicolás Mendoza. He's going to speak about vasomotor and genitourinary.
Good afternoon. In the next minutes, we are going to talk about the vasomotor and genitourinary symptoms in the section of the clinical impact of menopause. Firstly, vasomotor symptoms are the most typical and frequent, affecting about 60–90% of menopausal women, and 20% of them affect seriously their quality of life. Vasomotor symptoms include hot flashes, night sweats, palpitation, insomnia, paresthesia, headache, and dizziness. In Spain, for example, the most frequent is insomnia, more frequent than hot flashes. It is interesting to highlight that there are situations or risk factors that increase the frequency and severity of vasomotor symptoms. For example, stress, perhaps the current situation of COVID-19, obesity and diet, tobacco and alcohol intake, gynecological situation like premenstrual syndrome. Another controversial factor, but in this case, physical activity, or more exactly, regular physical activity. We have described in this paper that regular physical activity reduces the vasomotor symptoms. Regarding the physiopathology of hot flashes and any kind of vasomotor symptoms, various neurophysiological or neuropathological mechanisms have been replicated in the origin of the vasomotor symptoms. For example, kisspeptin, neurokinin B, kind neurons, another bias like serotonin and norepinephrine neurotransmission. But always with estrogen decreased in the background. In another presentation, you will see that these are the basis for the use of effective alternative treatment to the hormonal menopause therapy, NK3 antagonists, or selective and serotonin inhibitors. Another interesting fact that we can show in this presentation is the possible relationship between vasomotor symptoms and cardiovascular risk. For example, in this slide, I show a meta-analysis showing that a relation with cardiovascular event. And that risk has been found to be independent of other risk factors of cardiovascular event. However, the pathophysiological mechanism that link them, cardiovascular event and vasomotor symptoms, are not clear. Probably oxidative and stress or cortisol secretion up in the background of this link. The second part is about genitourinary symptoms. And now we prefer to use the term genitourinary syndrome of menopause that vulvovaginitis, because it's medically more acceptable than that vulvovaginal atrophy. Genitourinary syndrome of menopause is defined as a collection of symptoms and signs associated with a decrease in estrogen and other steroids involving changes to the labia, clitoris, vestibuli, vagina, urethra, and bladder. The syndrome may include, but is not limited to, genital symptoms of dryness, burning, and irritation. Also sexual symptoms of lack of lubrication, discomfort or pain, and impaired function. And urinary symptom of urgency, dysuria, and recurrent urinary tract infection. As in now, vaginal health depends on the balance between vaginal trophies and vaginal ecosystem. And vulvovaginal congestion and lubrication is dependent on estrogen and testosterone. So, genitourinary syndrome of menopause affects about 20% of perimenopausal women. This data increased to the 50% of postmenopausal women, and also increased up to the 17% of women older 70. The diagnosis, sorry, I have to come back. Yes, sorry. The diagnosis of genitourinary syndrome of menopause is clinical, anamnesis and physical examination. Some complementary tests, such as pH, can be performed, although they are not necessary. So the diagnosis of sign and symptom, such bulbar, stenotic introitus, labia minora agglutinated, thin epithelium, red net. In vagina, decreased vaginal fold and secretion, thinner vaginal mucosa. In two Spanish studies, or in two Spanish participation in multicentral studies, dyspareunia as was the bothersome symptom in general. In our country, it's a concern about the insufficient awareness of physicians about sexual health. So, in conclusion, in that presentation, we say that vasomotor symptoms are very frequent symptoms that seriously affect quality of life, that several hypotheses have been postulated with a common background, the estrogen decrease, that genitourinary syndrome of menopause is the new term involving changes vulva, vagina, urethra, and bladder associated with steroid decrease, and dyspareunia and sexual dysfunction are frequently described. Thank you very much for your attention.
Now we would like to ask you to please rate this session from 1 to 5 stars. I would like to introduce you now to Dr. Alejandra Herrera. She's going to speak about psychological domains.
Good afternoon, my name is Alejandra and I'm a gynecologist from Malaga, Spain. I'm going to talk about psychological domains in cancer survivors. Being diagnosed with a cancer is a turning point that will mark a lifetime. It's a stressful event that, to a greater or lesser extent, it will condition a before and after, beginning from mental health. Healthcare providers have focused largely on patients' physical symptoms and physical health status, and less emphasis has been placed on mental health issues. Anger, fear, and anxiety used to be are the most common symptoms at the diagnosis. But the true magnitude of the problem comes out when everything is supposed to be finished and the battle has apparently been won, at least physically. Cancer survivors are more than twice as likely to have disabling psychological problems compared with adults without cancer. The prevalence of common mental disorders among patients with cancer varies widely in the published literature, from 5 to 50%. This wide variation is due to several factors, including treatment setting, type and stage of cancer, and method used to screen symptoms. Risk factors for poorer mental health include younger age, to be a woman, to have a lower educational level, a greater number of non-cancer medical conditions or comorbidity, lower income, not be partnered or married, and prior mental pathology. The first 1 to 3 years after treatment are a critical period which to monitor the mental health in cancer survivors. Mixed emotions are common immediately after treatment. On the right, we can see the main psychological symptoms in this period. We are going to comment them separately. The first few months after treatment, it is particularly common to feel abandonment and isolation. Finished treatment makes them feel that they are not receiving the previous level of support, and simultaneously the fear that cancer will come back again appears now that they are not undergoing treatment to prevent it. Furthermore, in many cases, family and friends don't know how to help them to decrease their stress level. And this is why some of them just feel understood by healthcare professionals or other cancer patients. Even the fear of recurrence or that they can die may interfere with the quality of life of cancer survivors and put pressure on relationships. Some patients express anger. This is very common at the beginning after a cancer diagnosis, but it can appear once they have finished treatment as well. They may be angry because family or friends have not supported them during treatment, or maybe their body have failed them, or they had a late diagnosis, or even they can direct their anger toward themselves because they blame themselves for what has happened. Many of them are going to experience an existential crisis, trying to look for the purpose of life or what they value most, or just to focus on their spirituality. This path helps them to handle the new situation, which is colloquially known as the new normal. They may be told to go home and return to their previous normality, but it's not possible for many of them because of physical and psychological limitations. Roles and responsibilities in the family, as well as relationships, need to be reestablished. Once patients gain some distance from their diagnosis, they may try to see it as a life lesson and change their mind into a positive way of looking at the experience. Some will try to sort out what they did wrong in the past and will start to make changes into their lives, like having a healthy lifestyle, working on their relationships, or just engaging with nature more closely than before. Cancer treatment has a substantial impact on women's bodies. Those who has experienced a loss of their bodies physically or in function, like a breast, ovary, or uterus, are going to express grief and loss because their fertility, femininity, or libido may have been attacked. Premature menopause can induce depression, anxiety, poor body image, and sexual dysfunction. Many will even grieve the loss of their dreams, hopes, and aspirations. Talking about psychological symptoms, distress is the main one. All patients express distress in response to a cancer diagnosis and treatment effects. About 1/3 of cancer population will experience significant levels of distress requiring targeted psychosocial interventions. Distress is endorsed since 2010 as the sixth vital sign, and it can occur on a spread spectrum from an adjustment disorder to a psychiatric illness, like a major depressive episode. Several studies have shown that distress is under-recognized in cancer programs. This is why it's so important that healthcare professionals screen their patients using a simple non-diagnostic tool such as the distress thermometer, DT. This is an instrument validated by the National Comprehensive Cancer Network to know patient distress based on one ETEL numerical rating scale from 0 to 10. Patients mark their level of distress over the past week on the visual representation of a thermometer, and a score of 4 and above is indicative of distress. Next to the thermometer, the Canadian Partnership Against Cancer has included a short list of problems in 5 areas: practical, family, emotional, spiritual, and physical, in which patients can answer yes or no, helping physicians to know which areas are more affected. Depression affects 20% of cancer survivors and anxiety around 10%. Literature shows that the prevalence for major depressive episode in these patients is around 15% and 20% for minor depression. It's been estimated that 11% of women with gynecological cancer are going to have a depressive episode, as well as 9% of breast cancer survivors. The American Society of Clinical Oncology, ASCO, published adapted guidelines for screening, assessment, and treatment of anxiety and depressive symptoms in adults with cancer in 2014. They provide screening tools and follow-up care to help healthcare physicians to screen cancer patients and to select those who need to be referred to mental health professionals. They recommend that all patients with cancer and cancer survivors should be evaluated for symptoms of depression and anxiety at periodic times across the trajectory of care. For depression screening, they use the 9-item Personal Health Questionnaire, PHQ-9, to assess for the classic depressive symptoms and anhedonia. And for anxiety screening, they use the Generalized Anxiety Disorder GAD-7 scale. They provide recommendations about education and coping skills when patients' symptoms are known or mild, and seek consultation with a professional, psychologist or psychiatrist, when symptoms are moderate to severe. As with any screening approach, the screening alone is not enough, but it must be the first step to trigger a response from a healthcare team if a patient score exceeds a threshold value. Despite of knowing that psychological symptoms can have a negative impact on quality of life and can make the transition to new normal difficult, there is evidence that many cancer survivors will not receive adequate help from a mental health professional. Therefore, it's important that all health professionals, like oncologists, primary care physicians, or other specialists who treat cancer patients, develop some tools of mental health providers to detect when the psychological symptoms are over the normal reaction to cancer. Screening should be followed by a more comprehensive and focused assessment to guide the selection of appropriate and relevant interventions, as well as the need to referral to psychosocial resources. Before finishing my talk, I would like to highlight some messages to take home. Psychological symptoms are up to 2 times more frequent in cancer survivors than in the general population. First 1 to 3 years after treatment are critical for mental pathology. Psychological symptoms can make the transition to the new normal difficult. At the present time, many cancer survivors are not adequately screened for psychological symptoms, since they are not established guidelines to assess mental health in this population. Health professionals should develop tools of mental health practitioners to screen their patients for mental health status. To end, I would like to quote a Viktor Frankl's phrase related to this topic. When we can no longer change a situation, we are challenged to change ourselves. Thank you very much for your attention.
Now we would like to ask you to please rate this session from 1 to 5 stars. I would like to introduce you now to Dr. Eva Iglesias. She's going to speak about sexuality.
Good afternoon. I'm going to talk about sexuality during and after cancer. I hope it's useful and you like it. Let's get started. First of all, it's important to bear in mind that sexuality is an essential and primordial aspect of human beings, present from our conception to our death. It includes much more than sex or corporality. It includes the physical, psychological, emotional, and social aspect of sex that make it unique for each person. And is it an important problem in cancer patients? It is, and that is because the advances in oncology treatments result in an increased population of cancer survivors, and sexual dysfunction are one of the most prevalent concerns. In fact, the National Institute of Cancer estimates that 40 to 100% of cancer survivors suffer from dysfunction or sexual difficulties. It's also known that the most prevalent complaints in women are low desire, pain during intercourse, or difficulty or inability to reach orgasm. We all know that a cancer diagnosis implies a vital rupture, with changes in every life aspect, not only concerning health, but also work, relationships, social activity, thoughts about the future, etc. That means that worries about health can negatively influence the interest in any kind of sexual activity. Fears and doubts, the illness itself, and the effects of the treatments may cause that the person doesn't feel in an optimal state. The social environment, family, and the quality of the relationship with the partner are very important. To be able to communicate is essential for psychological well-being. As the person returns to normal routine, interest in sexual activity may resurface. Sexual activity is going to decrease initially, but physical contact is necessary to calm the patient's fear and to improve their self-esteem. However, in most cases, patients don't feel worthy to be touched and avoid any type of contact. Feelings and thoughts can also affect sexuality. We can be facing wrong beliefs, such as lifestyle as the cause of the cancer. For example, previous sex lives as the cause of a cervix cancer or not having had children as the cause of a breast cancer. The patient can feel really guilty about it and even reject any kind of sexual activity in the future. Depression is very usual and affects self-esteem, self-image, and the interest in sexual activity. Anxiety is also common. A cancer diagnosis can affect and worsen problems with the partner. And women who aren't in a relationship may avoid new sex partners due to fear of rejection. Finally, previous attitude towards sexuality is essential. If it was positive, it's more probable to continue with their sex life. And it's not only about psychological aspect. We are going to face different side effects of the treatments. For example, surgery. Generally, it's going to affect the patient's body image and self-esteem, and that appears to be especially important in breast or colorectal cancer patients. In women suffering from breast cancer, sexual dysfunction are more prevalent when a mastectomy is performed, and as the breast may represent femininity or sensuality. In patients dealing with colorectal cancer, dysfunctions are more common in case of an ostomy. In general, surgical treatment in cases of gynecological cancer may affect women's reproductive ability. Many women associate sexuality to reproduction. Therefore, after surgery, there is no reason for them to have sex. Another important issue is the state of the vagina after surgery or radiotherapy. The vagina may shorten and narrow, making penetration painful or even impossible. And if coitus is their only sexual practice, their sex life may be over too. And also, we are going to face many side effects due to medication. Chemotherapy can cause sexual dysfunction, alteration in sex drive, infertility, weight gain, and hair loss, among others, which seriously affect the patient's self-esteem. It can also cause mucosal inflammation or even sores, which make difficult some kind of physical contact, such as oral sex or even kissing. Now that we are aware of this problem, what can we do? The most important thing is to ask our patients and let them know that they can talk to us about anything that affects them. We must be proactive and ask questions about this topic in any appointment. We should normalize these subjects in our daily practice. But then, why don't we do it? Because there are still barriers in our work environment. The patient may feel ashamed to talk about sex. Maybe she doesn't know how to ask for help. She can consider that it's a temporary problem, that it's not important, and it's maybe normal with aging. And lastly, she may feel lack of intimacy or empathy with her doctor. And what happened with us? Medical doctors aren't usually trained in sexology, and it's really common feeling unsure about what we do. We have few minutes with each patient. Many doctors may feel uncomfortable talking about sexuality. Some professionals may think that this is not a health problem when dealing with cancer survivors. And finally, our own beliefs. We may not consider the need of a sex life in single patients, all patients, or even those with metastatic disease. We should learn and practice sexual counseling. It has 4 steps. The first one, information. We can solve a problem only after this step. We need to talk about the wrong beliefs I mentioned earlier. We must listen and answer any question the patient may ask. Talk about expectations and reality and help them to adapt to the new situation and condition. And also, we have to inform our patients about possible treatment options for the problem. The second step would be to correct modifiable factors that may create or worsen sexual difficulties. We have to promote a healthy lifestyle, avoiding habits such as smoking, recommending a healthy diet and exercise, and correcting hypertension or diabetes. We can also adjust any medication that may have negative effects on sexual response. For example, changing one drug to another with less side effects when it is safe and possible. And finally, we have to deal with any other physical condition our patient may be experiencing, such as the state of the vagina, everything that we may be able to improve. The third step would be to promote sexual relations as a source of health and well-being. We have to provide our patients and their partner with resources to get more understanding, realistic and positive towards sexuality. In most cases, we'll have to work to improve their self-esteem. Also, techniques to cope with anxiety and tolerance for frustration may be needed. We should advise to avoid dramatizing the situation. It is generally a matter of acceptance and time. We must encourage other types of sexual relations, promoting sensuality over sexuality. Advise to stimulate the rest of the body and not only the genitals, for example, with sensual massages. Finally, we should recommend enjoying sexual relations without having a sole and mandatory goal, meaning the orgasm, learning to get pleasure from physical contact and mutual communication. And step 4, working with the couple. We must promote co-responsibility, meaning that each person is responsible for their own enjoyment. We cannot leave everything in the hands of our partner. We have to evaluate the partner's attitude. Maybe the other person is afraid to touch the patient, or maybe they are not interested in improving the situation. Very important. We have to encourage communication within the couple and help them improve his quantity and quality. The couple should be able to talk about anything, including sexual issues, if something is unpleasant or painful, or even their mutual desires and fantasies. They should also be able to talk about their fears. We should suggest increasing creativity, and erotic games or other different erotic resources may be useful for this. Also, generating a pleasant atmosphere may be essential. it is also important to spend time with each other, even scheduling some time for sexual practices in their daily activities. And finally, we can provide help to change aspects of the relationship that may affect it, such as gender-related roles or dealing with anger or fights. And that's all for me. Thank you very much. Feel free to ask any questions you may have.
Now we would like to ask you to please rate this session from 1 to 5 stars.
Now, we would like to present the next session, Debate with JUMP Mentees, presented by Professor Dimitrios Goulis. Thank you for your attention. Now you will have the same 5 questions with 20 seconds each. The results of the selections will be shown and will be checked whether the knowledge has been improved, so please pay attention to the questions.
Θανάση, από εδώ και πέρα όσο μπορείτε σιγότερα. Ευχαριστώ πολύ, Θανάση. Hello, everybody. I think you are hearing me. On behalf of Professor Antonio Kono, the president of EMAS and organizer of this unique congress, it's a great pleasure to welcome you on this second live session. I saw with pleasure that the performance of participants had been improved during the second round of the multiple choice questions, and this is a first evidence that the seminar is indeed informative and educative. We have the opportunity to watch 5 excellent lectures dealing with different aspects of the topic we are discussing this today, and this is living with and beyond cancer. The Congress has another unique characteristic. The first part of the discussion is dedicated to the participants of, I would say, the mentees of the JUMP, the Junior Mentoring Program, a project developed by the European Menopause and Andropause Society to assist young scientists during their first clinical and academic steps. So let's kick off immediately with the questions from the JUMP members to our panel. I think that there is a question to Dr. Hassian from Dr. Angelescu. Delia? Delia, can you hear me? Can you put your first question to Dr. Hassian?
Yes, immediately. Different drugs have a different impact on future health. So, Do you think it may make any sense to create something like a scale of risk stratification depending on treatment received, which would be variables of interest for that? Age of the patient, for example?
Thank you for your questions. Well, the thing is that different drugs have a different impact on different aspects of health. So it makes sense to create a prognosis calculator, but for the different aspects of health that we may consider of interest. For example, if we are talking about a cardiac risk, then we will have to consider age, chest radiation. We will have to consider the anthracyclines as a chemotactic chemotherapy drug, or if the patient has high cholesterol or high blood pressure. Whereas, for example, if we want to consider or we want to make an estimation on a premature ovarian insufficiency, we will have to consider age before treatment, or the use of alkylating agents, pelvic radiation, the antral follicle count, or MMH before treatment, as the use of, if analogs were used during chemotherapy and so on. So for such a prognosis calculation, we will have to develop different different scores with a different weight of the different aspects to be considered.
Nice, very nice. Professor Quereda enlightened us about the role of surgery, the actual role of salpingo-ovarectomy. I think there is a question from Dr. Armeni to Professor Quereda. Anastasia? Anastasia, can you hear me? You have to unmute your microphone.
Hello? Can you hear me?
Yes, Anastasia, very well. Please proceed with your question to Professor Quereda.
My question to Professor Quereda is the following. Anything else you would like to add about differences in approach of risk reducing bilateral salpingo-ovarectomy for BRCA1 and 2 mutation carriers?
I can see that there is a problem with...
I think, yes, there is a problem with the microphone.
Okay, so we keep this unless we have a safe connection. So I would imagine to proceed with the next question. And this is from Dr. Moccia to Dr. Mendoza. So it has to be about vasomotor and genitourinary symptoms. So Pierluigi, would you like to pose your question?
Yeah, thank you very much, Professor Goulis. I'd like to ask for Dr. Mendoza. First of all, I'd like to say it has been a nice speech. Thank you very much. I'd like to ask you about the role of the tibolone in patients who had the previous cancers and has vasomotor symptoms and genitourinary syndrome.
Okay. Thank you, Luigi. Yes, do you hear me?
Very well.
Yes, but I don't hear you so good. Perhaps the problem is mine. Pierluigi, thank you very much for your question. My talk is not about treatment, but I like tibolone is a very good treatment. It's a very good hormonal menopause treatment. Your question is about the randomized clinical trial about the Liberate. It was, I think it's more than 10 years ago, liberating women in breast cancer survival who were hot flashes and other symptoms. Tibolone have more increment of breast cancer than control group. In my opinion, it's only my opinion, is the only randomized clinical trial who tried to use hormonal treatment in breast cancer survival. With because at the first time, Tibolone seems to be the less the hormonal treatment with less increase of breast cancer metastases. So in my opinion, I think it's a very good treatment for this kind of women. But of course, year after the diagnosis of the cancer, is in the point of view of treatment of vasomotor symptom or even genital urinary symptom, is a very good treatment because has the both effect androgenic and estrogenic effect. So a lot of women can improve vasomotor symptom and even genital urinary symptom taking Tibolone.
Nice, very nice. Thank you very much. So let's move from the somatic to the psychological domains. I have another question from Dalia Ancelescu, this time from Dr. Alejandra Herrera. So Dalia, would you like to pose your question? Dalia, can you hear me?
Yes, do you hear me?
Yes, very well.
Okay, now I can put my question. What are the factors or conditions that promote the onset of psychological symptoms in cancer survivors?
Good afternoon to everybody. Can you hear me?
Yes.
Very well.
Well, so the impact that cancer can have on a psychological level, it will depend on many factors, mainly 5. Firstly, the characteristics of cancer, diagnosis experience, type of cancer, stage, prognosis, and if they have physical symptoms or functional decline. Secondly, cancer treatment modality and dose, side effects, long-term complications, costs of treatment, or response to treatment. Furthermore, cancer treatments, including immunotherapy or chemotherapy, can induce depression through particular biological mechanisms such as inflammatory pathways. Even chemotherapy can reduce dopaminergic transmission, which is implicated in the development of depressive symptoms. Thirdly, individual factors can predispose to psychological problems, such the age. As I said in my talk, younger people are more likely to have psychological problems than older people. This can happen because maybe they have more concerns about developing long-term life projects, or about reinsertion into the labor market, or about feeling dependent. And other individual factors can be gender, sexuality, genetics. Fourthly, psychological problems depend also on social factors, like employment status, educational level, household income, social and family support, and even the healthcare system. And fifthly, one of the most important factors is a pre-existing mental health problem, like a prior depressive episode or anxiety or substance abuse. The risk of suicide among cancer survivors is higher than in the general population. So this latter is the key that should make us think that a person is prone to developing a mental illness throughout her lifespan. So I think these are the main factors to develop psychological problems in cancer survivors.
Well, thank you very much, Dr. Herrera. I can see from the system that Professor Quereda is with us. So most probably, Anastasia, could you repose your question to Professor Quereda?
Yes, of course. Good afternoon. One more time. Professor, anything else you would like to add about differences in approach of risk reducing bilateral salpingo oophorectomy for BRCA1 and BRCA2 mutation carriers?
Yes, thank you very much. I was telling that because it allows me to reinforce one of the messages that I wanted to give to the audience. You know? We have been managing these patients as an only group, and we have been recommending bilateral salpingo-oophorectomy as soon as possible, and now we know that there is no reason for that, because they both have an increase, BRCA1, BRCA2, an increase in cancer risk. But the main risk, which is risk of mortality, which is ovarian cancer, they have some important difference. One of them, the age at the usual age at the beginning, which for BRCA2 is 8 to 10 years after. And the second is the type of breast cancer, which is more usual, hormone dependent, and with better prognosis. If we keep in mind both things, we could recommend them, and these are the actual recommendation. Not going to an early menopause, surgical menopause too soon, because we are increasing the risk of mortality. And the other thing, the other important difference is about HRT use after the procedure, because the earlier procedures are for BRCA1, and there is no data of increase on mortality for breast cancer for these people after HRT use after BSO. So I think we are going to keep in mind that they are different populations for decisions.
Thank you very much, Professor Quereda. Last but not least, we heard an excellent talk by Dr. Iglesias about sexuality. I have a question from Dr. Marquina. So, Irina, would you like to pose your question to Dr. Iglesias?
Yes, thank you. And thank you everyone for your great presentations. Dr. Iglesias, if you don't mind, what is your opinion regarding communication with our patients about sexuality, or actually the lack of communication? Do you think this could be the hot potato of the issue? And if so, what is your advice?
Hello, everybody. Can you listen to me?
Yes, we can hear you.
Okay. Thank you for your question. That was a very important part of my presentation. That we don't talk to our patients. Our patients don't talk to us either, because they are afraid or they are embarrassed, and we should be proactive, asking them and letting them know that they can talk to us. Because that's, I think, if we do that, if we are able to ask some question, and they know that they can talk to us. We inform and we how can I say that? We resolve their problems just with answers. Half of the work is done, I think.
Thank you very much.
Thank you very much. Stefan, I don't know if we have some questions from the audience. Yes, we have. So let's continue with this. We have completed one round. Let me read the first question. Oh, we have many. Nice. In patients with diagnosis of DCIS, estrogen negative, 10 years back, can they have low-dose vaginal estrogen? Is ospemifene better? Who would like to ask this? To answer this? Most probably Dr. Asian, would you like to deal with this?
Let's see. Okay, so a low estrogen dose through vagina can be used. Ospemifene has also been proven, but there's not so much evidence on that. So if I had to choose between both treatments, I would be going for the estrogen tablets per vagina.
Mm-hmm. Very nice. Another one from the audience. In patients with BRCA1 after risk-reducing BSO, can they have testosterone added to HRT? I think this may go to Professor Quereda.
Yes. There are a very, very short series of data, but and the usual management is to introduce first estrogen therapy, and after, if you think that you haven't gotten your objectives, your goals, perhaps for some women introducing androgens, given the fact that we know that the androgen levels are very low, perhaps is going to improve their quality of life. And this is my experience. For some women who have androgenic deficiency syndrome, usually they are going to improve in your quality of life throughout the introduction of testosterone. But using only testosterone have some contradictory evidence, and it's not usual to do that, only androgens. But after the introduction before of estrogens, yes, and I have some experience about that.
Thank you very much. Thank you very much, Professor Quereda. A question for Dr. Herrera. When you talk about depression, are you talking about a clinical diagnosis of depression according to DSM-5 criteria?
Hello. Well, when I talk about depression, I'm not talking about a mental disorder diagnosed by DSM-5. I'm talking about disabling depressive symptoms. Most of the questionnaires used to detect symptoms in cancer survivors for screen cancer survivors are not valid to diagnose mental illness. There is little data on the prevalence of mental disorders diagnosed according to the DSM-5 manual in cancer survivors. Some of the reasons could be because, well, there is a recent study that shows that only a third of patients with cancer and emotional distress or psychological symptoms were willing to be referred for support. So that shows that the stigma surrounding mental health conditions persists nowadays. And this is the cause that many patients may not disclose psychiatric symptoms.
Nice, thank you very much. I have a question about adolescents. So are there questionnaires appropriate for young patients, for example, adolescents? I think that this may go to Dr. Iglesias about sexuality, and most probably Dr. Mendoza may have add something about vasomotor and genitourinary symptoms. So, Dr. Iglesias, about sexuality, something appropriate for young patients? Can you hear me, Eva?
Yeah. I had the micro off. I had technical problems. Adolescents, I think they are especially difficult group of patients, if that's what you mean. Cancer in adolescents?
No, about specific questionnaires about sexuality in adolescence.
Okay.
How can we approach them? Yeah.
Okay. There are FSFI is the one of the most used one for size and works, and we have also the QOL that has a specific questionnaires for breast cancer and colorectal, and I think another type of cancers. I work with breast cancer, so I'm aware of that only. But there are, and that have questions referring to chemotherapy, the repercussions of the chemotherapy on sexual dysfunctions and everything.
I see. Dr. Mendoza, are there any specific approach? Do you have any recommendation for young patients, adolescents with vasomotor or genitourinary symptoms? If you can unmute yourself.
Sorry. We can talk about young women with precoce menopause, but I don't know in the case of adolescent. We can talk about young women with this kind of process, even adolescent with any kind of amenorrhea, central amenorrhea like anorexia, another kind of amenorrhea. In that situation, the percentage of women or young women with vasomotor symptoms, even with genitourinary symptoms, is less than the older women. We don't know the reason, but in general, young women with precoce menopause has less symptom of this kind, but they have more psychological symptom that older women. Perhaps the reason is the stress, the cortisol secretion, but really we don't know the reason why these women have a less symptom than older one. In this case, we recommend contraceptive hormonal with estrogen because they are still gain both mineral density, both mineral bone and any kind of cardiovascular health, etc.
Thank you very much. As you have the microphone, Dr. Mendoza, I have a question by Diana Mihai. What do you think about CO2 laser treatment for vaginal atrophy after cancer treatment in order to improve the genitourinary symptoms? So the role of CO2 laser.
Okay, that is a very, very good option. We just published a systematic review about the treatment of breast cancer survivor with any kind of treatment. The result of the systematic review is that any kind of treatment is good for these patients, even the estrogenic treatment. But a very good and new option is the treatment, the non-hormonal treatment. For example, CO2 laser. There are, I think there are 3 or 4 randomized clinical trials in progress, of course, even without result, but it's a very, very promising option for this kind of for these patients.
I see. Thank you very much for this answer. Obviously, the majority of our audience are gynecologists, so Professor Quereda has a lot of questions. So for Professor Quereda, is the mortality rate similar for young women without menopausal hormonal treatment after the completion of orectomy for endometriosis? Is this similar as for BRCA carrier?
Yes, we have data from the general population, which shows us that younger women under 45 after BSO without HRT users, without HRT use, increase their mortality. So it's an important matter, it's an important topic which implies that we must not remove the ovarian if it's not necessary. And after that, if we have done, we might seriously think in HRT use if it's possible.
Thank you very much. And probably you would like to answer this as well as a general question. How often would you screen for cancer survivors? So how often would you screen them?
For cancer survivors?
Cancer survivors, exactly.
Yeah. We do following the usual protocols for the type of cancer which has suffered the patient, of course. If the question was directed for the fact that perhaps she is using HRT, the same as other patients on HRT. Usually once a year for more of them. And at the beginning, perhaps more frequently because it's useful to it increase the compliance.
I see. Thank you very much. I think we have concluded a very vivid question, and I have to thank very much all of you, the audience, in this very nice interactive course, as well, of course, of our participants that have delivered their speeches and have been involved in this very nice and very stimulant discussion. I think we are exactly on time, so I would like to give the microphone to our president, Professor Antonio Cano, who did his best actually and succeeded very, very well to have this interactive meeting. So please, Professor Cano.
Thank you, Professor Goulis, and congratulations for the excellent session, which has been as good as the previous one. I think it has been a very good experience to have this model of short talks with plenty of debate, with young doctors who are keen in many aspects of this great topic, and also with the whole audience. We have today reviewed important aspects related with cancer survivorship. We have reviewed the most frequent cancers, gynecological and breast cancer, also endometriosis. Then we have reviewed areas like bilateral salpingo-oophorectomy and the impact of medications related with cancer. And now we have started the part of the clinical impact, which we will follow tomorrow. Today it was interesting to review aspects of sexuality, psychological aspects, and also the genitourinary syndrome and the vasomotor syndrome. So I think the conclusion for today is that we are extremely happy for the result, extremely happy for bringing to the society this topic, which is growing, because this type of patients is something that we have more and more. We have commented about the impact, for example, in adolescence. Also, we have to think that cancer in childhood has an impact in many aspects related with health, with fertility, etc. Then we have many young women suffering from the impact of the medications, of surgery, which obviously bring a list of different situations to the clinician, which require a response. Just thank you again to the speakers, to the moderators, to the participants, the discussants, the audience, and also our technical support. And just we will continue tomorrow. Have a very good evening. Goodbye.